And our objectives for this lesson is at the end of the presentation, you should be able to define sleep-related breathing disorders. You have to define obstructive sleep apnea, discuss the pathophysiology of your OSA, state the different diagnostic tools used in, of course, the diagnosis of your OSA, and most importantly, you will be able to outline now an effective respiratory care management plan, which is actually the most important thing that I would like you to have after having this presentation. Okay, please excuse me for the typographical error here. Next is, again, as I've said, why are we talking about sleep-related breathing disorders? While in fact, as I've mentioned in my opening slide, it is about your obstructive sleep apnea. Well, because your OSA or your obstructive sleep apnea is actually classified under a bigger classification, which is known as your sleep-related breathing disorder. So as you can see, you have a lot of disorders classified under your sleep-related breathing disorder. And that is actually your, one is, again, as I said, your obstructive sleep apnea disorders, which is actually the most common sleep-related breathing disorder. That's the reason why that is actually the thing that we will focus our lesson. And of course, you also have, by the way, in your obstructive sleep apnea, you have to remember that OSA is not only seen in adult patients, but you can also see OSA in pediatric patients. Okay? So when you talk about OSA, you can actually talk about OSA in adults and OSA in pediatrics. When you talk about your central sleep apnea disorders, this, on the other hand, is again one of sleep-related breathing disorder, which affects now the central control. I mean, it affects now the rhythmic control of your breathing, which is actually seen in your brain. So one common disorder classified under your central sleep apnea disorder is your CSA with Kind-Stokes breathing disorder or breathing pattern. You can also have your CSA related to medications or substances induced by your patient. And as you can see, this type of breathing disorder will, again, as I've said, will affect now your control of breathing, which is actually located in your brain. Another breathing disorder that we need to or classified under your sleep-related breathing disorder is your sleep-related hypoventilation disorders. What is a common disorder classified under this one? One is actually your OHS. I hope you have heard of that. And that is what you call as your obesity hypoventilation syndrome. So that is actually classified under your sleep-related hypoventilation disorder. And then, of course, you have your sleep-related hypoxemia disorder. So again, as I've said, we will be concentrating our discussion on your OSA, which is actually one of the most common sleep-related breathing disorders. It's usually in your REM sleep, usually makikita mo, core temperature drops, you have changes in your respiratory patterns, and usually your waveforms are actually so mabilis yung ano nito. That may also explain why your heart rate will also become irregular during this time of sleep. When you will get your blood pressure, usually in your NREM sleep, your blood pressure is stable. You do not actually see changes in your blood pressure. However, if you go into your REM sleep, it becomes increasing and decreasing. So you see transient changes in your blood pressure. I guess that will also be logical because your heart rate also becomes irregular at this stage of your sleep, no? That's the reason why your blood pressure will also be increasing and decreasing. So it becomes erratic. It follows also that when you talk about your cardiac output, in your NREM sleep, since your blood pressure is also stable, this is the time that your cardiac output will also decrease. You have to remember that if you will correlate it, usually, for you to be able to understand, no, bakit ganito ang nangyayari pag natutulog tayo? And then there are sudden changes. It depends on what stage of sleep you are in. Of course, we have mentioned that when you talk about sleep, no, that's the time that all your muscles are also relaxed during this time. So when you talk about your muscles, your heart muscles are also considered as muscles. So it's also their time that they will not be uh, moving or performing work so much because nga you are in your relaxed state, supposed to be, okay, when you are sleeping. So it follows that your cardiac output will also decrease in your NREM sleep. And then when you go into your REM, you can see that further your cardiac output will decrease. Actually, medyo, because your blood pressure becomes transient, you see transient changes because you will see increasing and decreasing pattern in your blood pressure. That, I guess, will also explain why your cardiac output will also be decreasing further because nga erratic yung inyong blood pressure. That's the reason why your cardiac output will also be decreasing at this point in time. No, respiratory rate, again, as I've said, normally in an awake person, definitely you have to, your body has to um, adapt also to the activities that you have. While when you will be sleeping, definitely you do not have, you're not so active when you are talking about sleeping, tama? So everything, again, as I've said, will be relaxed. Even your breathing pattern should be relaxed. Kaya medyo magdi-decrease yung inyong RR during this time, no? And then when you go to your REM sleep, babaliktad na naman. So you will increase now your respiratory rate. So might be if you have a bed partner, kung meron kang kasamang natutulog, may kapatid ka, kasama mo mga kapatid mo, uh, if you are married, then definitely you are with your husband or your wife, no? Definitely, you will see, try to observe, no, the patterns that you have in your bed partner. So siguro pag medyo decrease yung kanyang respiratory rate, tapos eventually biglang bibilis, o might be that person is already in the REM sleep. Kaya biglang bumilis yung kanyang respiratory rate. Okay? When you talk about ventilatory drive naman, while a patient is on your NREM sleep, usually you expect that there is a decrease in your tidal volume. That is also, again, as I've said, logical because your respiratory rate will be lesser. So it follows that your tidal volume will also be decreasing. So you also see, since you have a decreased tidal volume, you also expect that your responses to hypoxia and hypercapnia are also decreased. Okay, so because you do not have so much ventilatory drive, okay, for you to be able to respond now, I should say, to your hypoxia and hypercapnia. And then when you go into your REM sleep, definitely you will also see a significant decrease in your ventilatory drive. So it follows that at this point in time, no, you will see further decrease in your responses to hypoxia and hypercapnia. Okay? So this is the time that usually pag siguro when you talk about later on, we will see what happens in a patient suffering from OSA because normally in a normal individual not suffering who is not suffering from obstructive sleep apnea usually presents with a decreased ventilatory drive, decreased tidal volume. You also see a normal physiologic change which is associated with a decreased responses to hypoxia and hypercapnia. Normal na yun na nangyayari, no? Without OSA. However, that will be significant in a patient who is suffering from obstructive sleep apnea. So yan na yung mga changes na nakikita natin that will actually be significantly seen in a patient suffering now from your obstructive sleep apnea. And then when you talk about your muscle tone, When you talk about your NREM, usually your muscle tone is similar to wakefulness. So, ibig sabihin nun, that when you are aroused, no, pag ginising ka during this time, no, you will expect that you will be active. So, magigising ka pa. Pwede ka pang manuntok siguro dyan during the time pag bigla kang biniglang ginising or prinank or whatsoever. Okay? And then when you talk about your muscle tone during your REM sleep, eto na, you do not actually see muscle tone. Ito yung sinasabi nilang para kang na-paralyze. Okay? You are already on your REM sleep. So you do not expect muscle tone to be present here. So maybe this is what happens when you are already, if you have heard yung stories na sinasabing pumasok ang magnanakaw and yet you haven't actually or seen somebody kasi nga you are already on your REM sleep, which means that your muscle tones are actually absent. Okay? This is actually the stage na. Again, as I've said, these are the different waveforms that I have mentioned a while ago. So alpha waves, sabi natin, alpha waves, usually this is how it looks like when you talk about your alpha wave. Alpha wave usually is seen in your stage W or your wakefulness stage, no? So it is usually 8 to 13 hertz. And again, as I've said, this is seen in your stage W. That's why it's commonly associated with EEG arousals. Okay? Your theta waves are also known as your low voltage mixed frequency. So this is what you see. This is how it looks like when you talk about your theta waves, which usually is seen in your stage N1. Okay? So it's usually characterized as medyo mas mababa as compared to your alpha waves, which is actually fast. That's the reason why if you look at it, it's between 8 to 13 hertz, and your low voltage mixed frequency wave or your theta waves are usually slower. Kaya makikita mo then you see changes also in the speed of your waves. Okay? So because it's usually between 4 to 7 hertz. And again, as I've said, you usually see this one in your stage N1 or the transition stage from your stage W going now to your stage N1. Okay? And then your sleep spindles, these are actually your sleep spindles in your K complexes. Usually makikita mo medyo nag-iiba yung pattern ng inyong waveforms, no? Because your sleep spindles usually are brief bursts of high frequency. Makikita mo parang pabugso-bugso yung mabilis at saka matataas na waveforms. Okay? And that will also be seen because the characteristics of these waveforms usually is ranging the fast or how fast it is. It's ranging from 11 to 16 hertz. And again, as I've said, your K complexes naman, they have a unique waveform. So makikita mo, if you will compare it with all the other waveforms, usually malalaki sila tapos medyo parang kakaiba yung itsura. Okay? And your sleep, your K complexes usually are followed by sleep spindles. Okay, lagi yan. That is also logical because usually this type of waveforms is seen in your stage N2. Okay? So medyo papunta ka na doon sa stage na medyo malalim-lalim na yung tulog mo during this time. Okay, so before finally we will be talking about your obstructive sleep apnea, I would just like you to look at the different terminologies that we often encounter when you talk about your obstructive sleep apnea. Okay, so we have to be familiar with this one because when you are talking about obstructive sleep apnea, you will often hear these terminologies. Okay, so when you talk about apnea, that is usually the cessation of airflow for at least 10 seconds. And you expect that the airflow will decrease by more than 90%. So, ibig sabihin nun, you will see na parang kung siguro if you will look at your pattern here, ito yung flat. Okay? Wala kang makikitang waveforms. It's just a flat line. Why? Because there is cessation of airflow. Ibig sabihin nun, walang lumalabas at walang pumapasok na hangin. And usually, airflow is decreased by 90%. Okay, and you have to remember this one. It happens for at least 10 seconds. Nakakita ba kayo? Try nyo kayang hindi huminga for a period of 10 seconds. So that is what you call as an apneic episode. Okay? Hypopnea, on the other hand, is a reduction in your airflow more than 30% for at least 10 seconds. In here, you will still see that there is waveforms, no? Kung i-correlate natin with the presence of waveform, ito ang apnea, it's purely flat line. But in your hypopnea, you will still see waveforms. However, it is actually reduced. Kaya nga hypopnea ang tawag dyan. So you expect that there is reduction in airflow. However, it will also last for at least 10 seconds or more. And then you expect that there is desaturation already that you see in your patients. So with more than 3% desaturation from the normal oxygen saturation that you see, no? With patient not suffering from hypopnea. The next one is your RERA, or your respiratory effort related arousal. Okay, so what is RERA on the other hand? It's actually arousal seen on EEG, which is commonly caused by a decrease in your airflow, okay, that doesn't qualify either as an apnea or hypopnea. So hindi mo siya ma-identify whether it's apnea or a hypopnea. However, there is a decrease in your airflow. Okay? So that is what you call as your RERA. Obstructive sleep apnea, on the other hand, is a respiratory event characterized by a continued thoracoabdominal effort in the setting of a partial or a complete airflow cessation. Ibig sabihin nun, when you talk about obstructive sleep apnea, you will see, that's why it's known as obstructive sleep apnea. No? Because you will see that the patient is performing efforts to maintain now or to correct now the respiratory event that is happening. So it can be caused by a partial or a complete airflow cessation due to an obstruction in the airways of your patient. That's why it's known as your obstructive sleep apnea. Central apnea, on the other hand, is that a respiratory event characterized by lack. Okay, so makikita mo a big difference. Why? Because in here, the patient still has an effort to correct now the abnormal respiratory event. However, in your central sleep apnea, there's actually the difference between the two, because in your central sleep apnea or central apnea, you do not actually see abdominal effort that the person will actually manifest during the time that there is partial or complete airflow cessation for a period of 10 seconds during sleep. Okay? If you have a mixed apnea, it means that you have a combination of both obstructive and central features. Okay? For you to be able to understand this one better, no? Usually, a very good illustration, we can actually have a very good illustration for this one, because in a patient suffering from obstructive sleep apnea, you will see, I don't know if you have seen somebody who has undergone um, polysomnography or your sleep study. Usually, if a patient is suffering from obstructive sleep apnea, you will see thoracoabdominal efforts. Okay? Makikita mo na yung you have kasi mga chest at saka abdominal belts that you usually place for your patient. And you will see that the patient has an effort. So makikita mo yung marirecord mo, no, yung electromyogram na I mean the muscle movements that you see will record that the patient is trying to correct now the apnea. While in your central apnea, nagkakaroon ka na ng apneic episodes. However, you will not actually see thoracoabdominal efforts. Kaya wala kang marirecord na movements coming from your abdomen and coming from your thoracic cage. Okay, so that's actually a very big difference when you talk about your central sleep apnea or central apnea that you see. Why? Because the problem here is usually related to the brain. Again, as I've said, alam natin that usually the control of breathing is seen at your brain. However, if the problem lies in your brain, definitely walang magti-trigger doon sa breathing muscles mo for you to increase now the respiratory rate or increase now your respiratory drive, which is not seen in your central apnea. While in your obstructive sleep apnea, no, the problem lies in the obstruction of your airways. Okay, may obstruction, may nagbara doon sa lalamunan or within the airways of your patient. However, the brain function still intact. That's the reason why if the brain will actually sense that there is a sudden decrease no in your respiratory drive, then definitely they will send signals now to your thoracic cage and to your abdominal muscles for you now to increase your respiratory rate and for you to increase now your respiratory drive. Kaya makikita mo gumagalaw pa yung inyong mga thoracoabdominal muscles. While in your central sleep apnea, you do not actually see such things occurring in your patient. Of course, mixed apnea, again, as I've said, is a combination of both problems. So you will see that you will have obstructive sleep apnea at the same time as central apnea in your patient. Okay? So other than that, again, as I've said, you have different measurements for you to uh, say that the patient is suffering from sleep-related breathing disorders, then you have measurements or you have different indices that are actually recorded and measured. And that is becomes now, or that becomes now the basis of diagnosis. Okay? So one is your apnea index. What is your apnea index? It's actually the average number of apnea per hour of sleep. So when you talk about you have a 10 apnea index, ibig sabihin nun, that is actually the average number of apnea that happens within 1 hour of sleep that is recorded. When you talk about apnea threshold, usually it is defined by a PaCO2 level below which the respiratory output ceases primarily, resulting in a central apneic events. Okay? And then when you talk about your hypopnea index, that naman is the number of hypopnea events that has been recorded per hour of your total sleep time. And then of course your AHI, which I know has been a common term that you have often heard or encountered when you talk about your OSA, no? Apnea hypopnea index is the number of complete airflow cessation and the number of your partial obstructive events per hour that is recorded during your total sleep time. So again, as I've said, your AHI or your apnea hypopnea index now is the one that they use for you to classify the disorder, whether it is severe, moderate, mild, or a very severe problem. So they base that on the apnea hypopnea index, no, based on the one that is recorded. And then your respiratory disturbance index, on the other hand, is the average number of respiratory disturbances that includes now your apneas, hypopneas, RERAs per hour of your total sleep time. So, ibig sabihin nun, a combination of your apnea, hypopnea, and RERAs during your total recorded sleep time is what you call as your respiratory disturbance index. Okay, so let's try to look at in particular your obstructive sleep apnea, okay, because that's actually the concentration of our discussion for today. So sleep apnea by definition is, again, as I've said, I have actually given the definition a while ago, but for you to have a better understanding of what the problem is, it's actually an abnormal condition. Yes, it's abnormal because you usually do not see the events that are happening in your OSA normally, okay, in an individual. So it's characterized by recurrent episodes. Again, the term recurrent episodes which is seen as either a complete or a partial interruption of airflow due to an upper airway collapse. That happens during your sleep, and you also see not only an airway collapse, but you also see airway obstruction. Okay? That is the reason why, because of the upper airway collapse and because of the obstruction that you see, which is recurrent, ibig sabihin nun, paulit-ulit, and of course, it can be a complete or a partial one, it leads now to episodes of apnea, episodes of hypopnea, and episodes of RERA. So when you talk about your obstructive sleep apnea, you have apnea, hypopnea, and RERAs happening, okay? All at the same time. And of course, again, as I've said, one thing that you have to take note of is there is an interruption of airflow because of an upper airway collapse or an obstruction. Okay, yan yung problema, kaya nga obstructive sleep apnea. And because of that obstruction, you expect now that the movement of gas, particularly inside of your airways, is not seen because either you have a complete or a partial obstruction that you see in your patients. Commonly, there are different signs and symptoms that you see in a patient suffering from OSA. One is actually, I guess this is one of the most common symptom. So if a patient comes to you and usually will be referred not to a polysomnography clinic or a sleep study clinic, usually the number one complaint is actually a very loud and persistent snoring, because mostly, if not all, patients suffering from obstructive sleep apnea will present with a loud, persistent snoring. You have to understand also that though it has been happening for quite some time, no, hindi nila nire-report kaagad yan. What I mean is that even if the patient has been suffering from this condition, usually it doesn't, the patient or the bed partner usually will not complain uh, at this point in time until such time that they will have now there is already disturbance in the sleep. No, na pati yung kanyang bed partner hindi na rin makatulog. That's the reason why you will have now problems, and that's the time that they will come to the clinic or they will seek consult now because of such problems that you see in your patients. Okay? And then, you also see that there are witnessed apneas. Bakit nakalagay witnessed apneas? Because usually, again, as I've said, definitely pag ikaw yung taong tulog and you are the one suffering from obstructive sleep apnea, hindi mo makikita na nagkakaroon ka ng apnea. But again, as I've said, apneas, the person who will actually identify that you are really having apneic episodes is actually a bed partner. Okay? Kung sino yung kasama mong matulog. Kaya nga witnessed apneas. You will also see that these patients will have frequent awakenings or frequent arousals. Yung laging magigising. And then, usually the awakening or the arousal is accompanied by a gasping or a choking events. Okay? I don't know kung nakakita kayo, but I have actually witnessed several um, uh, patients who are suffering from sleep apnea, and makikita mo talaga yung pattern, no, that usually before you will have the choking events, makikita mo that there is an increase in the intensity and increase in the loudness of the snoring. So mag-uumpisa pa lang yan. Kumbaga, if I'm going to illustrate it, usually pag ganyan pa yan hanggang sa lalakas yung snore niya hanggang sa andun siya sa peak, and then that's the time that magkakaroon ng gasping or choking event, and then magkakaroon ng apnea. Okay, so apnea, and then magigising ulit yung tao. So you will have now again the normal pattern. Okay? Hanggang sa mauulit na naman yan. So again, as I've said, anong napansin nyo? Para siyang Stokes breathing pattern, no? But usually, if I'm going to illustrate it, usually, a person suffering from OSA will manifest with So you have the choking and the gasping events na. And then magigising yung tao because they have actually choked. And then eventually, pag nagising siya, okay, babalik na naman siya sa normal. So normal breathing pattern. And then eventually, you will have again presence of snoring. Habang papataas yung intensity and habang papataas yung loudness, no, of the snore, that's the time that you will have now the next thing that you will see there is actually the choking events, no? O kaya kung hindi, what happens is that until such thing as you have the highest snore, biglang titigil yung paghinga ng pasyente mo. Okay? And then after that, that's the time that they will have the choking or the gasping events. Okay? A very good thing about, the thing that you see there is may pattern siya na ganun. So kung titingnan mo, paumpisa, palakas, 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 and then biglang hindi hihinga yung pasyente. Okay? So bibilangin mo, how many seconds will that? And then after that, by the time that you will have now the build-up of your CO2, biglang mag-choke yung pasyente or you will have the gasping. Gaganon yung pasyente and then magigising siya. So those are the awakenings with choking or gasping events. Patients also suffering from OSA will have cognitive deficits. Why is that so? Because they really do not have a good night's sleep. Sabi nga nila usually, makikita mo na pag ikaw kulang ka ng tulog, pagkagising mo kinabukasan, you are irritable. And sometimes you have cognitive deficits. Why? Because I've mentioned a while ago that while you are sleeping, that's the time that your brain will process all the informations that you've had for the day. So kung hindi maganda yung tulog mo, definitely your neurons are not actually wired correctly. Okay? So nagkakaroon siguro ng hindi magandang pag-wire o kaya hindi nagko-connect yung dapat mag-connect na neuron. Kaya you have your cognitive deficits. Okay? Since you do not have a good night's sleep, you expect that you have daytime sleepiness or daytime fatigue. Kagigising mo pa lang ng umaga, usually parang antok ka na tapos parang pagod na pagod ka. And usually if you will interview, if you will conduct your medical history taking, that is also one of the problems that a patient will manifest. Okay? They will also complain of dry mouth upon awakening. Okay? So parang magang-maga yung kanilang bunganga. Next is a patient may also suffer from gastroesophageal reflux. Okay, that is also seen. And patients will also complain of lack of concentration. If you happen to see some news events that will feature somebody na parang truck driver tapos nabangga and everything, usually if you look at their history, if you look at their profile, might be they are suffering from OSA. That's the reason why they have what you call as these types of what you call this one, accidents or incidents that happen. Because during that time, hindi sila makakonsentrate kasi nga antok na antok. And by the time na bigla silang natulog na, they are holding a machine, no? They are holding the driving a vehicle. Tendency is, ito yung time na nababangga sila kasi nakakatulog or natutulugan nila. They conducted actually a study in the United States and they found out that usually road traffic accidents or vehicular accidents are commonly seen in patients who are suffering from OSA. Okay, so a number of incidents. is actually correlated with presence of obstructive sleep apnea. Again, as I've said, I mentioned about mood changes. So patients can become irritable kasi nga they do not have good night's sleep. While you are sleeping, that's also the time that your body will regenerate, ika nga. That's the time that your body will actually have its time na magpapahinga din, na even your muscles will actually, they're given the time to rest and to freshen up, I should say, to become refreshed. However, if you do not have that one because you did not have a very good night's sleep, because you have been having frequent arousals, frequent awakenings, nagkakaroon ka ng choking, gasping, and all the like, no, definitely it follows also that you have several mood changes. And you will also hear patients suffering from OSA complaining of morning headaches. Pagkagising pa lang nila, sakit-sakit ng ulo. The reason for that is that they have a very high PaCO2 in their blood levels. Siguro kung i-ABGs natin itong mga to, they actually have a very high CO2 levels. That is the reason why they have severe morning headaches pagkagising pa lang nila. Okay, why? Because definitely, ikaw ba naman kung ganun yung tulog mo, no? You have really an increase in your PaCO2 kasi nagkakaroon ka ng apneic spells. And you know that during the time that you are apneic, definitely that's also the time that you have the buildup of your PaCO2 in your blood. Okay? So that will also explain why these patients will really have morning headaches. And they have also conducted a study that those patients who are suffering from hypertension, those who are suffering from diabetes, often are suffering from OSA. And once you correct the obstructive sleep apnea, eventually the hypertension, the blood sugar increase are also corrected. So ang problema pala, the reason why a patient is suffering from hypertension or from diabetes, increase in blood sugar levels, is actually due to presence of lack of sleep that is usually seen in a patient suffering from OSA. So if you are that person who is actually suffering, might be you may want to be evaluated. Baka meron kang OSA. What are the different risk factors in the development of this condition? Well, advancing age, no? So we know that once you age, definitely. However, let me remind you again that OSA is not, again, just seen in adult patients, because I mentioned a while ago that pediatric patients also have uh, obstructive sleep apnea. Well, if you talk about, si segue lang ako, when you talk about your pediatric OSA, usually the common reasons why you have OSA in this group of people or in this group of patients is actually abnormality, no? Abnormality in their anatomical airways. Kaya sila nagkakaroon. Kasi kung titingnan mo, bakit nga ba magkakaroon ng OSA? Mga bata sila. Well, again, as I've said, commonly, this group of patients suffer from abnormalities in their airways. That's the reason why you have now your OSA, or they manifest with OSA. So again, as I've said, going back, advancing age, yes, they have found out that the more that you age, no, chances of developing now your OSA is actually higher in this group of patients. Why? Because usually as you age, again, as I've said, as you age, you also see that the tonicity of the muscles, no, are also decreasing. Kaya it follows that habang tumatanda din yung inyong mga muscles. That includes also your oral muscles and your breathing muscles. Okay? So it follows that you have that kind of higher risk. Male gender, why male? In particular, they conducted actually again a study related to this one, and they have found out really that male patients are often seen as the ones who are reporting OSA. Why? Because it has something to do also with their anatomical structure, And again, as I've said, if you look at it, mas sila yung correlated sa alcohol consumption, smoking, and all the like. Well, I'm not saying that women cannot also have OSA, because there are certain reported patients also who are females, I should say, are also suffering from OSA. Okay? Again, is menopause. Why is menopause related now to the development of OSA? Well, it has something to do with hormones. Okay, your estrogen and progesterone, usually these hormones will help now increase the tonicity. No, they cause the muscles to become toned, and will prevent airway collapse. However, as a woman goes into menopause, definitely the levels of estrogen and progesterone will also decrease. So again, as I said, these hormones will help in the increasing the muscle tone. At syempre, pag nag-decline yan, when you have now your premenopausal to menopausal up to postmenopausal, definitely your levels of your estrogen and your progesterone will also decrease. So you also decrease now the hormones that will increase or will improve now muscle tone and will prevent the airway collapse. Kaya menopause is also correlated with the presence of obstructive sleep apnea. Well, again, as I've said, the most common, siguro if you look at it, the most common cause of your um, obstructive sleep apnea is actually obesity. Because commonly, if you see the profile of your patient suffering from OSA, usually they are considered obese. If you will get their BMI, magpo-fall talaga sila ng obese. And aside from that, if you look at the neck circumference, or if you measure the neck circumference of these patients, usually the neck are short and it's actually large, no? Kaya it follows. If you look at the profile, again, as I've said, of a patient, no, male gender, tapos obese, tapos they are short neck, usually they also suffer from OSA. For sure yan. They have OSA. Again, as I've said, if you have nasal and oropharyngeal, sorry for this, ano, oropharyngeal anatomy abnormalities, no, in your nasal and your oropharyngeal anatomy. Lately, I have been suffering from, what do you call this one, epistaxis, and I went to an ENT, and I found out that I have turbinitis. And when the physician was actually conducting my medical history, he often asked if I have snoring, if I have nasal congestion, which I found out that eventually, later on I realized na oo nga, pagdating ng gabi at pagdating ng madaling araw wherein usually the temperature has changed, no? I often have nasal congestion, and I also have seen that I happen to experience also snoring. And according to the physician, usually the nasal anatomy, no, my turbinitis is the one that is causing now the snoring and the nasal congestion. And because of that one, it led to the development of epistaxis. Okay, so eventually when the turbinitis has been resolved, then nawawala din yung snoring, nawawala din yung nasal congestion, and eventually the epistaxis is stopped. So again, as I've said, in correlation to this one, nasal and oropharyngeal anatomies usually will predispose an individual to develop obstructive sleep apnea. No? So again, as I've said, ito yung common na nakikita natin sa mga pediatric patients because they have nasal and oropharyngeal abnormalities in their anatomy. That's the reason why sometimes they are really suffering from nasal congestion also. Kasi because of the abnormalities in their nasal and oropharyngeal anatomies, it also led now to the development of your OSA. Or sometimes, no, I don't know if you have heard about patients who are suffering from macroglossia, or yung malalaki ang dila usually will have also higher risk for the development of OSA or what you call as your neck retrognathia or macrognathia o kabaliktaran retrognathia, umurong yung kanilang chin, no? And then when you say macrognathia, nawawala naman yung kanilang chin or lumiliit yung chin. And usually these abnormalities are also correlated with the development of your obstructive sleep apnea, which are common manifestations no in patients who are on pediatric patients who are suffering from your obstructive sleep apnea. Okay? Patients who are smoking and who are having alcohol consumption are also at high risk of developing obstructive sleep apnea. Yes, because as you know, smoking can actually cause a lot of problems, not just OSA, but a lot of lung problems. Okay? So wala talagang magandang idudulot ang smoking. Recently, we have actually uh, celebrated your no tobacco smoking day. And I hope that we all join in this advocacy as respiratory therapists in the future. No, this is actually one of our responsibility also to advocate for a no to smoking and no to vaping. Okay? Because as you can see, smoking will not only lead to COPD, asthma, but can also lead to the development of your obstructive sleep apnea. And of course, alcohol consumption. The reason for this one is, again, as I've said, you know that alcohol can be a good can induce muscle paralysis. And when you have your muscle paralysis or when you have the relaxation of your muscles, it follows, again, as I've said, when you talk about your airway muscles, no? Nagkakaroon din yan ng relaxation, nagre-relax din yan. That's the reason why there is greater risk of developing now your obstructive sleep apnea, no? Which is correlated with increased alcohol consumption to this one. Because again, as I've said, once the patient will go into your hypoventilation, no? The next step there is you have the narrowing and collapse of your upper airway. So that's the time that we use now your CPAP or your positive airway pressure devices, or in some, they are using oral appliances. Yung mga nilalagay anyway, back later on. But again, as I've said, the gold standard in the treatment of your sleep apnea is actually your positive airway pressure. So it can be delivered in three ways. You can have your CPAP or your continuous positive airway pressure. You have your auto positive airway pressure or what you call as auto CPAP. Okay? Or your APAP na tinatawag natin. And of course, you have your BiPAP or your bi-level positive airway pressure and your adaptive support ventilation. So all of these are actually considered as positive airway pressure therapy. So what is actually the principle behind your positive airway pressure is, again, as I said, we have seen in the pathophysiology that the patient, after the hypoventilation, the patient will actually go into your will go into the what do you call this one, narrowing of your upper airway. So the positive pressure that is given by these devices will maintain now the patency. Okay, they prevent now the collapse of these upper airways. Kaya continuously during the breathing cycle, the positive pressure will prevent now the collapse of the upper airway. Kaya mapiprevent din yung obstruction that you see in the airways of these patients. So that's basically the principle of your positive airway pressure therapy. And then of course, these are the common devices that you commonly have, no? So your CPAP will deliver a continuous positive airway pressure during your inspiration and expiration. So if you look at this one, this graph, no, in your CPAP, no, this is actually the air pressure from your continuous positive airway pressure. Okay, the blue one is the one that is manifested during the breathing process. Okay, so as you can see, the continuous positive airway pressure will actually prevent now the collapse of your airways. Kaya continuous din yung breathing ng iyong pasyente. Okay? And then your APAP, again as I've said, auto, positive airway pressure. Why auto? Because it is actually, it will cause now, it will sense now the changes in the pressure in the airways of your patient. So the difference is yung CPAP kasi once you deliver or once you give now the level of pressure, like say for example, if you have decided to give 10 centimeter water all throughout the breathing pattern during your inhalation and exhalation, the 10 centimeter water is actually given all throughout the breathing process. When you talk about your auto auto CPAP, no, usually it will actually adapt now. So during the inspiration, kung yun yung mas mataas dapat yung pressure na ibibigay mo, then the machine will actually adapt to that. And during your expiration, it has sense na hindi niya kailangan yung 10 centimeter water. It can actually fluctuate less than 10, then that is actually what the device will actually give. So it automatically increases or decreases the pressure depending on the patient's need. Yung CPAP kasi continuous yan. Whatever you have set, that is the one that is delivered by the machine. So whether ang kailangan lang ng pasyente mo is 10 centimeter water, if you have delivered 15, that is what you have set in your machine, all throughout the breathing pattern, 15 ang dinideliver niya. So that is the difference between your CPAP and your auto CPAP or your APAP. Wag natin. Bi-level positive airway pressure, on the other hand, kaya bi-level kasi you are delivering now your inspiratory positive airway pressure and an expiratory positive airway pressure, or you have a different IPAP and a different EPAP. Okay? Kaya bi-level. Okay? And this type of device is the treatment of choice for patients with your obesity hypoventilation syndrome, your patient suffering from COPD with components of your central sleep apnea. So in here, I would like to direct you here because this is actually a clear difference of your CPAP and your BiPAP, I should say. Again, as I've said, in your CPAP, it's continuous pressure all throughout your inspiratory and your expiratory. So let's say, for example, if you have set again a 10 centimeter water pressure, that is the pressure that is delivered during your inspiration. That is also the pressure that is delivered during your expiration. Okay? So all throughout the breathing cycle of your patient, whatever is your setting, that is the one that is delivered by your machine. While in your bi-level positive airway pressure, you have definitely a different IPAP and an EPAP. So let's say, for example, if you have set an IPAP of 15 and an EPAP of 10, during your inspiration, definitely 15 centimeter water is delivered to your patient. During your expiration, since your EPAP is 10, then during the expiration, it will deliver now, the machine will deliver now a 10 centimeter water pressure. So, they deliver now different pressures. Kaya nga bi-level, yung isa naman continuous. Okay? Your adaptive servo ventilation, or your ASV as what we call it, this is actually a type of BiPAP that uses now a servo controller that will automatically adjust the airflow to maintain a preset ventilation. Okay? So it provides also an adjustable EPAP to control now your obstructive events. Okay? So your adaptive servo ventilation is very useful in patients who are suffering from CSA with Kind-Stoke breathing pattern, especially if it's already complicated now with congestive heart failure. What is good in your adaptive, kaya din siya adaptive servo ventilation, because it provides now dynamic adjustments during your inspiratory pressure support and an automatic backup rate. Okay? That is actually used to normalize now the breathing pattern relative to a determined target. Yan yung wala sa inyong CPAP and BiPAP because you have in your adaptive servo ventilation, you have an adaptive backup rate. Okay? So in here, kung makikita natin, no, usually this is what you call as your Stokes respiration. So makikita mo, again as I've said, you have your apnea and hypopnea, and then of course periods of apneic episodes, no? So in here, you have set now your IPAP level. You have also set now your EPAP level. So while the patient is actually going into your Stokes respiration, your pressure support will also adjust, no? Depending on the need of your patient, depending on the breathing pattern that is given by your or that is manifested by your patient. So as you can see here, while the patient is actually on hyperventilation, hindi din siya magbibigay ng pressure support kasi nga the patient doesn't need a support in here. By the time that the patient will manifest with apnea, hypopnea events, that's the time that you will have also your increasing pressure support until such time na mawawala ulit kasi magka-hyperpnea ulit yung pasyente. So definitely your pressure support will be not given until such time. Kaya pati tingnan nyo pati yung waveforms on when your or what type of pressure support or what level of pressure support is given by the machine is also adaptable or it's also adjustable depending on the obstructive events manifested by your patient. So this is actually the advantage of your adaptive servo ventilation together with an automatic backup rate. Okay? Para pag yung time na nag-up na yung pasyente mo, definitely the machine will give now the needed backup rate. It's not just plain pressure support. Kasi kung nag-up na yung pasyente, just like in cases of your Stokes CSA, definitely you do not expect that there is a backup rate. Why? Because you have to remember, bakit ito magandang gamitin ng ASV? Kasi the problem lies in your central sleep apnea. Bakit hindi natin ito ginagamit with your obstructive sleep apnea? Because in here, no, in your obstructive sleep apnea kasi, you still have the thoraco-abdominal efforts because the problem is only on your obstruction of your upper airways. While in your CSA, the problem lies in the brain control. Kaya, walang effort na nanggagaling doon sa pasyente kasi walang nagtitrigger, no, for your breathing muscles to respond to such changes. That's the reason why they will benefit more if you will add now a backup rate. Okay, for you to normalize the breathing and for you to achieve now the needed target for your patients. Well, who are the candidates for your ASV? Definitely, they are those patients who are suffering from periodic breathing na tinatawag natin, whether they are normocapnic, meaning normal levels of your PaCO2, or whether they are hypocapnic. Good candidates also for your adaptive servo ventilation are those patients who are suffering from CSA or your central sleep apnea with concomitant obstructive events. Okay? Or for patients with more than 45% ejection fraction whose sleep disordered breathing are not controlled by your CPAP, BiPAP, or your positive airway pressure with oxygen. Or for those patients who have ataxic breathing episodes and for those who have neurologic problem patients will actually benefit more with ASV rather than the BiPAP or your CPAP. Okay? These are also other alternative therapies. Ito yung tinatawag natin na oral appliances that I have mentioned a while ago. So as you can see, these are your tongue retaining devices, no? For what is this? Again, as I've said, sabi ko kanina that during the time that you are sleeping, usually the tendency is your tongue to move backwards. So once you have now your tongue retaining devices, you expect that the tongue will actually be not retracted. So hindi magre-retract yung tongue with the help of this device. So it prevents now obstruction. Okay? This one naman, on the other hand, is what you call as your mandibular advancement device. So again, as I've said, sabi natin that the mandible, especially in your, that is actually the problem when you talk about your retrognathia or macrognathia, no? The problem is actually in your mandible. So the mandibular advancement devices will actually maintain the mandible and of course the size and its movement. Of course, another intervention is to perform now your surgical treatment. So again, as I've said, this is good for patients who are suffering from nasal to oropharyngeal abnormalities in their anatomy. So one is your uvulopalatoplasty, pharyngopalatoplasty or your UPPPP na tinatawag natin. So as you can see here, if the problem is actually in your uvula, okay, masyadong malaki yung uvula mo, tapos it adds now, sabi natin, once you sleep, this tongue will actually be moving backwards, tapos malaki pa yung uvula mo, and then definitely it adds to the obstruction. So a very good way for you to have that one is to remove now your uvula and paliliitin yung inyong pharyngeal tonsils. Okay, so tinatanggal ito. As you can see, no, kanina, ganyan yung opening with your uvulopalato-pharyngoplasty lumaki. So you have actually a lot of improvement that you see in the upper airways of your patient. And again, as I've said, these are commonly performed if the abnormality is seen in the anatomical structure, okay, of your patients. I don't know if you are familiar with what you call as your Malampati scoring. In your Malampati, this is actually a very good scoring for you to assess, no, the obstruction that is brought about by your oropharyngeal anatomy. Your Malampati score is also a good scoring for you to decide before intubation of your patient, no? Because a patient who is actually on a Malampati score of 1 and 2, then you can actually perform now your intubation using your laryngoscope. But if your patient is actually classified under Malampati 3 up to 4, ibig sabihin nun yung Malampati 3 kasi medyo konti na lang yung nakasilip dito. When Malampati 4, totally obstructed yan. Wala kang makitang opening once you assess your patient. No, you do not actually see an opening here kasi obstructed na yan with the palatine tonsils and of course the different your uvula plus your tongue. So talagang wala kang makikita dyan. So that's the time that you will have now your video assisted intubation na tinatawag natin. Okay? When you talk about your Malampati score of 1, ibig sabihin nun may butas ka pang makikita once you assess, once the patient will open. Pag Malampati score of 2, medyo obscured yung inyong, medyo limited yung opening. Malampati 3, definitely mas lesser, no? Konti na lang yung nakasilip dyan. Siguro 25% lang ang nakasilip. And then Malampati 4, totally obstructed. Wala kang makita dyan. So again, as I've said, those are the common abnormalities that you see in your nasal and pharyngeal anatomies of your patient, which are actually abnormal and will be corrected using now your surgical treatment. You have to remember that not everybody will benefit from this one because, again, as I've said, kung ang problema hindi naman dyan, then definitely you will not benefit from that one. Okay? But if it's corrected using a positive airway pressure because the problem is actually to maintain the patency by providing a positive pressure, then it will not actually lead to surgical treatments, no? So medyo doon muna tayo sa non-invasive rather than having your invasive procedure, particularly your surgical treatment.
Okay, so that will end our recorded lecture for polysomnography this morning. Then this afternoon at by 1 p.m. Please be back by 1